our review charts, the patients who suffer the most are almost always the ones who've escalated way too fast. And the patients with the best outcomes, the sustainable outcomes, the lasting results, are often the ones who held to a lower dose longer than the protocol suggested because it was working. Lowest effective dose wins. This is not a conservative approach. It's called precision medicine. All right, what does a GLP-1 actually do? It actually binds to a receptor in your brain, your gut, and your pancreas. It slows gastric emptying. It means food moves slowly out of your stomach. It enhances satiety, which means you feel full, and it modulates insulin release. This is why it initially was an insulin diabetes drug. These effects build over time. GLP-1 therapy reaches a steady state concentration in your bloodstream after approximately 4 to 5 weeks of consistent use. What that means practically, you may not feel the full effect of any given dose after you've been on it for several months. This is why escalation questions is actually, are you sure you've seen what this dose can do for you before moving on? All right, what happens when you escalate too fast? 3 things. Side effect compound, nausea, vomiting, constipation, fatigue. These are dose dependent. Most patients who feel miserable in GLP-1 therapy are not miserable because of the medication class. They're miserable because of the dose. We know this because when they reduce the dose 9 times out of 10, they feel better. Second thing, adherence collapse. I've seen in the ER patients who go home, stop injecting because they feel sick, then they go everything back that they lost. Dropping out is the worst possible outcome of a GLP-1 program. The aggressive dose escalation is one of the leading causes. Third thing, you lose the signal. You feel so terrible on a dose, you can't tell whether the medication is working or not. You can't tell whether your habits are working. The noise drowns out the data. Holding a dose, sometimes for 2, 3, 4 months, is not failure. It's called clinical judgment. Before I escalate a patient's dose, I ask 5 questions. These are the questions that separate a physician-led program from an algorithm-driven one. Question 1, is their current dose suppressing? Appetite suppression is the primary mechanism of action. If you're still thinking about food constantly, still driven by cravings, still eating past fullness, then we may have a dosing issue. But the question comes before the prescription change. Question 2, are you tolerating the current dose? Tolerance matters more than progress. I would rather have a patient lose a ½ pound per week with 0 side effects than a patient losing 2 pounds per week while vomiting every other day. The first patient will be in this program for 2 years, and the weight loss will be consistent and forever. The second patient will quit in 6 weeks. Question 3, are the behavioral foundations in place? This is where most programs fail to ask the hard questions. GLP-1 therapy is a tool. It's not everything. The structure around the tool, the protein intake, the resistance training, the sleep, hydration, is what determines whether your results last long after you stop the medication or not. If your behavioral habits are still being underdeveloped, escalating the dose faster to a given number on a scale does not help. It means you have a weaker foundation underneath it. The medication is doing all the work. I hate to break this to you, but that is not the way it needs to go. You're not building what you need to maintain. Question 4, does the scale trend look like over the last 4 weeks? I'm not making any dose decision based on one weigh-in. I'm looking at a trend. A patient who's lost 8 pounds over 4 weeks on a starting dose, that dose is working. There's no clinical justification for escalation. Question 5, is what's slowing progress a dose issue or a habit issue? Again, hard questions. If weight loss has stalled, the first question is, do we need to increase the medication? The first question is, what changed in the last 30 days? Sleep, stress, dietary patterns? If the behavioral inputs degrade, escalating the dose won't fix the habit. It will just mask it temporarily, then it will come back again. These 5 questions need to be asked every single time. What you won't see is an algorithm asking these questions. This comes from a conversation, comes from a doctor asking you the questions. Let me talk about why the lowest effective dose wins, not just clinically, but strategically. Headroom is a strategic asset. GLP-1 therapy has a ceiling. There are maximum approved doses for a reason, and once you're at the ceiling, you have no room to adjust upwards if you hit a plateau. Patients who start at the lowest dose and escalate slowly preserve that headroom. If they plateau at 6 months, There's no more room to move. If they escalate aggressively in months 1, 2, and 3, there may be near or at their ceiling, but with nowhere to go. Reason 2, lower dose equals lower cost. These drugs are super expensive, and they're entirely based on the dose. Patients who are using compounded therapy, the dose and cost are directly related. A patient who achieves their progress at a modest dose pays meaningfully less per month than a patient at a higher dose. Over the course of 12, 18, 24, 36 months, that difference is significant. Reason 3, the wean becomes possible. From day one, this program is based on designing a medication for independence. The end goal is not a patient who requires GLP-1s forever. It's a patient who has rebuilt their relationship with food, rebuilt their muscle mass, rebuilt their metabolic baseline, and can maintain their results at a lowest possible dose on or off the medication entirely. That journey is dramatic, easier for patients who spent months at moderate, well-tolerated dosing than a patient who maxes out their dose and has no physiologic anchor point to descend from. The program that gets you off medication safely is the one that never rushed you to the highest dose unnecessarily. This is the hard question. What do you do if your program isn't asking these questions? If you're currently in a GLP-1 program and your dose is being escalated on a fixed monthly calendar without a physician reviewing your specific results, your side effects, your labs, your behavioral progress, your weight loss, I want you to hear this clearly. You are not receiving physician-led care. You're receiving algorithm-driven access. Those are not the same things. And the difference matters, not just for your results, but for your safety. Here's what you can do. Ask your program, who is making the dose escalation decisions? Is it a physician reviewing my chart, or is it automated? Ask, what are the clinical criteria for escalation? If the answer is it's part of the standard program, that's not a clinical answer. Ask, can I hold at my current dose if it's working? The answer should be yes. If there's resistance, that tells you something important about how the program views your care. A good physician-led program asks these questions. I welcome these questions because they are justified clinically and ethically. So the last bit, how do I handle dose escalation here? Every dose escalation decision is made by me, Dr. Miranda. After reviewing your chart, your recent weigh-ins, your side effect log, your check-in notes, a discussion, everything. There is no algorithmically driven dose escalation. Here's what our escalation framework looks like. Hold criteria. We stay at the standard dose. If you are losing weight, be it a ½ pound to 2 pounds a week, that is weight loss. Why go up? To speed it up? That doesn't get you there faster, but does not help. What about the side effect profile? Are they intolerable? Are you having to take Zofran or something for nausea all the time? Are you constipated beyond belief? Those are important questions. Increasing the dose will just make those worse and make you miserable. Behavior changes. This is the hard one. This is the one where you have to look me in the eye on these calls and tell me, are you getting enough protein? Are you getting enough training? Are you getting enough sleep? If the patient is in a mid-plateau, but the plateau has begun in the last couple of weeks, we watch. All right. When do we move up? All right, we move up when food noise becomes loud again. When appetite suppression, despite doing everything we could, starts going away. We go up when weight loss has actually truly stalled, not slowed, stalled, 4 or 6 weeks. We go up when the current dose is fully tolerated and the behavioral inputs are optimized. What does that mean? You're okay. You're taking the medications, the nausea is controlled, the constipation is controlled, you're doing what you do. The last time we go up, when you and I have had a reasonable conversation about what the next step is. This is what clinical judgment looks like. We don't see this anymore. Medicine is being driven to an algorithmic state all across the board. It takes more time per patient to make these decisions, which is why we are different. Our program is also designed to be explicit about where you are and where you're going. The price decreases as you progress because the program is designed for you to need me less over time, not more. Less medicines, less everything to get you independent. That is intentional. It is a financial and clinical signal that our incentives are aligned with your outcome, not your continued dependency. Commandment is a mindset shift, not a dosing protocol. It says more is not always better. Faster is not always right. The goal is not to maximize the dose. The goal is to produce a sustainable, lasting metabolic transformation with the least pharmacologic burden. If you've been on GLP-1 therapy and feel like your program is just pushing you upwards without asking real questions, or if you're considering starting and want to do it right, I encourage you to look for a physician-led program that applies clinical judgment to your decision. If that's Summit Metabolic Health, thank you. The link to apply is in the description below. Our intake process is extremely simple. I review every chart, we have a discussion. And your first month is at our lowest onboarding price because we designed the program to get cheaper as you get healthier. That's what lowest effective dose win actually means. I'm Dr. Miranda. Subscribe to The Next Commandment. Share this with anyone you know who's going through this and has been handed a dose escalation without a conversation.